Hi guys! So today I wanted to dig into the most recent research on DID and with legit facts and hospitals and stuff like that, articles that I found interesting. So this first one is through Science Daily, and it was published November 3rd in 2022 by McLean Hospital. And what I found interesting about it is that they talk about the neuropsychopharmacology about the brain. Okay. A team led by investigators at McLean Hospital, the largest psychiatric affiliated of Harvard Medical School, and a member of the Mass General Brigham, has identified regions within the brain networks that communicate with each other when people experience different types of dissociative symptoms. Now, in this part here, it states, the scientists found that different dissociative symptoms were uniquely associated with connections of areas in brain networks that are responsible for cognition and emotion processes. We found that disassociation common to post-traumatic stress disorder and disassociation central to DID are each linked to unique brain signatures, said Lee Boyce. The team hopes that a better understanding of the brain correlates of disassociation will help to rectify historical misunderstanding about disassociation with DID, destigmatize these experiences, and contribute to reducing gender-related health disparities. We also hope it will increase awareness of dissociative symptoms and that ultimately clinicians will be more likely to assess for and consider these symptoms and to connect patients with timely and appropriate treatment, said co-senior author Melissa Kaufman, Director of Dissociative Disorders and Trauma Research Program. Now, in this next article, this is through Psychiatry Online, the American Journal of Psychotherapy. And what I found interesting with this one was that this was done online May 7th, 2024. Advanced research on the treatment of dissociative identity disorder with people with lived experience. And what was interesting is on this, for the doctors, they have Matthew Robertson, Laura Ward, Melissa Kaufman, you name it. So it's an interesting article. Now it states here in the abstract, dissociative identity disorder is a post-traumatic psychobiological syndrome that develops over time during childhood. Despite empirical evidence supporting the validity of this diagnosis and its relation to trauma, the disorder remains a misunderstood and stigmatized condition. This article highlights expert census guidelines and current empirical research on the treatment of dissociative identity disorder. In addition, the authors described the Lived Experience Advisory Panel called LEAP, which was designed to leverage the expertise of individuals with dissociative identity disorder to combat stigma and improve research. Also to improve clinical programming, professional education, and public outreach related to the disorder. This article also describes how LEAP members have partnered with other researchers to create new knowledge through participatory action research in order to advance equitable service provision and affect positive change. So I want to talk a little bit about that. My research, when I see my therapist once a week, I know she had mentioned that they connect, the therapists connect together and psychologists connect together, and they document the research of your treatment as a patient, and they share the information with each other. I've also had the experience of having students come in to gain credit points, learning about DID. So I'm pretty heavily involved into the research behind DID. Some of the methods used, again, I will repeat, are EMDR, DBT, CBT, EFT, and DNMS. It's a touch and go for a lot of people. Like some people have told me they haven't found a lot that helps with the DBT. And it depends on the therapist or doctor themselves too, how your treatment works out, if they're patient, if they're not, if they're male or female. Everything depends on how you earn trust with your therapist or doctor. But once the treatment starts working and time advances, it's kind of nice to be able to work through some of those issues, especially when you get through the stability part, which is, there's 3 stages, I'm told. The first is stability, the second is viewing the trauma, getting to know your alternative states, whatnot, and then the last, which is basically deciding if you're going to stay as a multiple or if you're going to start to fuse with your alters. I want to talk about the definition of fusing. I was told, and I've been told by others, that fusion is when you start to become co-conscious with your alternative states. So you become aware of some of their traumas, you become aware of some of the things they do, and there's a less amnesic barrier. According to TikTok, fusion is when 2 alters fuse together and they make a whole new alter. No. And then as far as that goes, once you start getting that co-consciousness and things are getting better, which takes quite a few years sometimes, for me it was anyway, then you get the final decision of integration. Integration is where your alter integrates into you. Basically the mind opens up and you get view of your trauma, what you've been through, the emotions, the body sensations, all that become yours. So as people have stated, alternative states don't die. They're just you. They're just pieces of you that are shut down that you can't connect with because of the trauma. So in this next article, which is probably going to be our last one because it's a long one, this is through the Harvard Review of Psychiatry, and it was copyrighted in 2024. And it's called Separating Facts from Fiction, an empirical examination of 6 myths about dissociative identity disorder. And it's got multiple people on the team here. It's got Bethany Brand. It's got Kruger, Middleton, and Warwick. And I've read some of Warwick's work too. Very good. So to begin with, it states here in the abstract, dissociative identity disorder is a complex post-traumatic developmental disorder for which we now, after 4 decades of research, have an authoritative research base. But a number of misconceptualizations and myths about the disorder remain, compromising both patient care and research. This article examines the empirical literature pertaining to recurrently expressed beliefs regarding DID. And it states, number 1, belief that DID is a fad. Number 2, belief that DID is primarily diagnosed in North America by DID experts who overdiagnose the disorder. 3, belief that DID is very rare. 4, belief that DID is an estrogenic rather than trauma-based disorder. 5, belief that DID is the same entity as borderline personality disorder. And 6, belief that DID treatment is harmful to patients. Clinicians who accept these myths as facts are unlikely to carefully assess for dissociation. Accurate diagnoses are critical for appropriate treatment planning. If DID is not targeted in treatment, it does not appear to resolve. The myths we have highlighted may also impede research about DID. The cost of ignorance about DID is high, not only for individual patients, but for the whole support system in which they reside. Empirical derived knowledge about DID has replaced outdated myths. Vigorous dissemination of the knowledge base about this complex disorder is warranted. Now again, if your therapist or your doctor, psychologist, whatever, psychiatrist, are good at their job with disassociation and trauma, they basically are going to investigate you. They're going to find your trauma history. They're going to find the misconceptions in your past, to the point of even like my therapist, who has even visited places where trauma has taken place. We've gone through my school records, my medical records, all that. So you remember those 6 things that I've read that are myths. It states here, notwithstanding the upsurge in authoritative research on DID, several notions have been repeatedly circulated about this disorder that are inconsistent with the accumulated findings on it. We argue here that these notions are misconceptions or myths. We have chosen to limit our focus to examining myths about DID rather than dissociative disorders or disassociation in general. Careful reviews about broader issues related to disassociation and DID have recently been published, and they have these little highlighted things. You can go in and read those articles as well. The purpose of this article is to examine some misconceptions about DID in the context of the considerable empirical literature that has developed about this disorder. Now, in this lower part, they actually talk about the research and how it's being discredited. And it's interesting because it says in the title, for the period 2000 to 2014, our search yielded 1,339 hits for a 15-year period. This high number of publications speaks to the level of professional interest that DID continues to attract. And it gives 4 categories, and you can look into them articles if you wish to. It would take me forever. And in the end, it says, an expanding body of research examines the neurobiology, phenomenology, prevalence, assessment, personality structure, cognitive patterns, and treatment of DID. This research provides evidence of DID content, criterion, and constructive fidelity, and it gives more articles. The claim that DID is a fad that has died is not supported by an examination of the body of research about this disorder. Now, another thing I want to talk about is myth 2, and it talks about the overdiagnosis in America. And as you can see from this chart here, that's not true. So it states here, first, our results show that DID is found in prevalent studies around the world whenever researchers conduct systematic assessments using validation interviews. This table lists the 14 studies that have utilized structured or semi-structured diagnostic interviews for dissociative disorders to assess the prevalence of DID. These studies have been conducted in 7 countries: Canada, Germany, Israel, the Netherlands, Switzerland, Turkey, and the United States. So basically, the whole of it is when people say on TikTok the research ain't being done, well, these doctors are doing a lot of research, and as I had stated previously, is I am part of those case studies and very heavily involved in understanding DID and getting through the myths and the misconceptions, especially on TikTok. So in this part here, it says the second line of research challenging the estrogenesis theory of DID documents the existence of disassociation and severe trauma in childhood records of adults with DID. Researchers have found documented evidence of dissociative symptoms in childhood and adolescence individuals who were not assessed or treated for DID until later in life, thus reducing the risk that these symptoms could have been suggested. And there's articles on that. The other thing I found interesting in this same paragraph is it talks about false memories. It states, noted that contrary to the popular belief that probing questions will either instill false memories or encourage lying, especially in dissociative patients, of our 12 subjects, not one produced false memories or lied after inquiries regarded maltreatment. On the contrary, our subjects either denied or minimized their early experiences. We had to rely for the most part on objective records and on interviews with family and friends to discover that major abuse has occurred. So in this part here, it talks about the inappropriate approach. There are therapists out there that just are so excited about having somebody that they think might have DID that they'll push the issue. And that is the concern that's growing also. And it states here, perhaps the introgenesis myth exists because inappropriate therapeutic interventions can exacerbate symptoms if used with DID patients. The expert consensus DID treatment guidelines word that inappropriate interventions may worsen DID symptoms. Although few clinicians report using such interventions, no research evidence suggests that inappropriate treatment creates DID. The only study to date examination deterioration symptoms among DID patients found that only a small minority, 1.1%, worsened more over more than one time point in treatment, and the deterioration was associated with re-victimization or stressors in patients' lives rather than with the therapy they received. The rate of deterioration of symptoms compares favorably with those for other psychiatric disorders. Now, why did I read this piece? Well, I want to make an understanding that when you go on media apps and you see people talking about DID, go back again on their timelines, which I've stated in other videos I've done. You go back to the beginning of their TikTok, let's say, and you find out that they're wanting to heal, wanting to get better, but then they get caught up in the DID community drama and the fictives and factives and non-human alters and dressing and all this misconception, okay? If you notice over time, a year or two, if they're on there that long, you will see a pattern of behavior that is not good. They will come up with new alternative states, new symptoms, new clothes. There's the new thing now where I've noticed there's gift giving in the DID community where they give each other gifts, wigs, clothes, candles, toys, you name it. And the thing is, with healing of DID, you want to be able to heal that alternative state and get better. And in the DID community on TikTok, they're literally wanting you to separate your alternative states more, giving them an individuality. Now, here in this part of the article, Bethany Brand and Lowenstein talk about the difference between DID and BPD. Okay. Recent clinical observational studies, as well as systematic studies using structured interview data, have distinguished between DID and BPD. Clinical symptoms and psychosocial variables that distinguish DID from BPD. Clinically, individuals with BPD show vacillating, less modulated emotions that shift according to external participants. In addition, individuals with BPD can generally recall their actions across different emotions and do not feel that those actions are alien or so uncharacteristic as they disavowed. By contrast, individuals with DID have amnesia for some of their experiences while they are in dissociative personality states. They also experience a marked discontinuity in their sense of self or sense of agency. Thus, the dissociated activity and intrusion of personality states into the individual's co-consciousness may be experienced as separate or different from the self that they identify with or feel they can control. So let me give you an example of that. There was a moment in my life where BPD was considered a diagnosis. However, what they found interesting was in my assessments was that they could ask me a question and I would answer it as best as I could and honestly as I could. But then, per se, an hour later, they'd noticed a shift in my behavior and they had asked the same question and it'd have a complete opposite, answer. So they knew something wasn't right. Now with BPD, it's more of an emotional, as they say, there's mood swings, shifts. That's why also I mentioned that, alternative states educating on DID is not healthy either, because you could say one thing and then your alternative state could say another and give a misconception on what is okay and what is not. Now again, keep in mind, I'm not reading the whole article. It would take forever, so I'm just reading pieces of the article. If you want to know more, look it up. Here it states, why is DID so often undiagnosed and untreated? Lack of training coupled with skepticism about dissociative disorders seems to contribute to the undercognition and delayed diagnosis. Only 5% of Puerto Rican psychologists surveyed reporting being knowledgeable about DID, and the majority, 73%, have received little or no training about DID. And it also shows the little blue highlights for them articles. Clinicians' skepticism about DID increased as their knowledge about it decreased. Among U.S. clinicians who reviewed a vignette of an individual presenting with the symptoms of DID, only 60.4% of the clinicians accurately diagnosed DID. Clinicians misdiagnose the patient as most frequently suffering from PTSD or CPTSD. They don't say CPTSD in here, but they should. The fact that it's not in the DSM is the reason they don't. Followed by schizophrenia at 9.9% and major depression at 6.6%. Significantly, the age, professional degree, and years of experience of the clinician were not associated with accurate diagnoses. Accurate diagnoses were most often made by clinicians who had previously treated a DID patient or who were not skeptical about the disorder. It is concerning that clinicians were equally confident in their diagnosis, regardless of their accuracy. A study in Northern Ireland found a similar link between the lack of training about DID and misdiagnosis by clinicians. Psychologists more accurately detected DID than did psychiatrists at 41% versus 7%. Australian researchers found that misdiagnosis was often associated with a lack of training about DID and with skepticism regarding the diagnosis. They concluded clinician skepticism may be a major factor in underdiagnosis, as diagnosis requires dissociative disorders first being considered indifferential. Displays of skepticism by clinicians by discouraging openness in patients already embarrassed by their symptoms may also contribute to the problem. So what they're saying here is that it's, again, a covert disorder. And unless they have some training, it's difficult. And it states here, in short, far from being overdiagnosed, studies consistently document that DID is under-recognized. When somatic research is conducted, DID is found around the world by both experts and some non-experts. Ignorance and skepticism about the disorder seem to contribute to DID being an under-recognized disorder. So they're saying, the destigmatization, the people acting inappropriately, not representing DID educationally, and even some therapists acting inappropriately. I've actually seen a therapist on TikTok that is putting on onesies and acting like a child while educating on DID, and I just don't think that's appropriate in any manner. Again, my own personal opinion, but how is that treating anybody? So I'm going to read a small part of myth 4, which is DID is an iatrogenic disorder rather than a trauma-based disorder. And it states here, one of the most frequently repeated myths is that DID is iatrogenetically created. Proponents of this view argue that various influences, including suggestibility, a tendency to fantasize, therapists who use leading questions and procedures, and media portrayals of DID lead some vulnerable individuals to believe they have the disorder. And boy, do we have the misleading on TikTok. I do apologize for my speech. Sometimes my voice gets caught up and I can't get a word out the way my brain sees it, and my mouth wants to say it. So here in this part, it talks about the study in Spanos and colleagues was limited by the lack of a DID control group. Several recent control studies have found that DID simulators can be reliably distinguished from DID patients on a variety of well-validated and frequently used psychological personality tests, e.g. Minnesota Multiphasic Personality Inventory. And they show the articles, you can link there. Forensic measures, neuropsychological measures, including brain image, blood pressure, and heart rate. So again, I repeat, your blood pressure will rise and lower, your heart rate will rise and lower, your brain activity will change. So there are tests. People keep saying, oh, no, it's, she's crazy. No, there's tests, and I've had them done, where it shows different variations, especially the difference between age-regress alters, teen alters, and me. These are things that are noticeable. The body can change. It's still the same body, even though you're switched to an alternative state. But the brain thinks it's at a specific age, causing these somatic effects with the body, causing the nervous system to override and whatnot, causing fibromyalgia. Some people, like I stated, but with being in that hypertension mode constantly, it changes the body's way of thinking and surviving. So it causes major issues as you get older. DID is very complex in that manner. And as you age, and if you don't get the treatment, you're going to have health issues. So last in this article, like I said, I had skipped some. You want to read the whole thing, go ahead. Is myth 6, which states DID treatment is harmful to patients, which is something that TikTok seems to be floating around quite a bit. Some critics claim that DID treatment is harmful. This claim is inconsistent with empirical literature that documents improvements in symptoms and functioning of DID patients when trauma treatment consistent with the expert consensus guidelines is provided. And then it states here, early case series and inpatient treatment studies demonstrate that treatment for DID is helpful rather than harmful. Across the wide range of clinical outcome measures, and then it gives a bunch of articles you can read if you want to do that, a meta-analysis of 8 treatment outcome studies for any dissociative disorder yielded moderate to strong within patient effect sizes for dissociative disorder treatment. While the authors noted methodological weaknesses, current treatment studies show improvement methodology over the early studies. One of the largest prospective treatment studies is the treatment of patients with dissociative disorders, TOP-DD study conducted by Brand and colleagues. The top DD study used the naturalistic design to collect data from 230 DID patients, as well as 50 patients with dissociative disorder, not otherwise specified, so OSDD, and their treatment clinicians. Patients and clinician reports indicated that over 30 months of treatment, patients showed decreases in dissociative issues, post-traumatic stress, and depressive symptomology, as well as decreases in hospitalization, self-harm, drug use, and physical pain. Clinicians report that patients' functioning increased significantly over time, as did their social, volunteer, and academic involvement. Secondary analysis also demonstrated that patients with strong therapeutic alliance evidence significantly greater decreases in dissociative PTSD and general distress symptoms. So again, you go on TikTok, you're viewing stuff. If they're not getting better, they probably aren't in treatment, and they're probably making most of the stuff up. There are case studies where you do decline some in treatment at the beginning. But again, why are you on TikTok or on social media apps trying to educate when you're in a decline? So this part here is one of my favorites. It says, Brand and colleagues, gives a little article you can go to, reviewed the evidence used to support claim of alleged harmfulness of DID treatment. They did not find a single peer-reviewed study showing that treatment consistent with DID expert consensus guidelines harmed patients. In fact, those who argue that DID treatment is harmful cite little of the actual DID treatment literature. Instead, they cite theoretical and opinion pieces. And there's like 6 articles there you can read. In their review, Brand and colleagues concluded that claims about the alleged harmfulness of DID treatment are based on one peer-reviewed publications, misrepresentations of data, autobiographical accounts written by patients, and misunderstandings about DID treatment and phenology of DID. So to end this, and you can go and read more, there's quite a bit more. You can go to the ignorance about DID, causes of myths, and whatnot, but this is going to be too long already. My advice is, do not take advice from somebody that doesn't read legit research, that doesn't dig into the books or dig into the research online that's legit, like NAMI and APA and psychiatry and med, you name it. These people, if you notice, they usually have high numbers. They usually want funding for something. And as you can tell from my page, I don't ask for a thing. It don't matter to me. I like the work. I enjoy doing the work because in the long run, it's helping me. And in the long run, it's giving you tips for you and your therapist. So to end this, you're more than welcome to use this in your therapy. You're more than welcome to talk to your therapist about previous videos that I have. There are tips. I give a little bit of my home life. If you notice in the numbers in my bio, it states what is for what. So you have 1 through, I think, 8, where it gives the numbers of what's, when I put the title, it'll give a number, and that's what the video is about. 2B is about books, 2 is about research, which is what this will be under. 6 is about my personal life, 5 is about medical information and things like that. And just go through and you'll find what you need. So, if you have any questions that are non-drama, please don't be afraid to ask down below. I can link you to research and whatnot. Previous videos have answers to a lot of your questions, so some of them I'm just going to link you to one of the videos, or just, like I said, check it out, read, study. It's the only way. I'm not going to lie, I have been at this for so long, and the healing process took me a long time, and I'm at 10 years right now, and I'm just finally getting to stable enough to handle things here at home, and go outside my home a little more. That one's a little tougher. It takes time. I work very hard to get better, and that's the idea, to love yourself, to get better with yourself. I've even had people that were friends of mine try to strew that I attacked or harassed them, when in fact it's more or less they're looking for somebody to give them attention, and they're not going to get it from me. So that's all I have today. Loves. Bye.